Hi guys. Sorry, my name is Mohammed. I'm going to be giving the lecture on behalf of SUPTA today. Sorry, Bianca, she's part of the committee for SUPTA. I think her internet sort of is not working at the moment, so we're just having some technical difficulties. So I think we'll start in a couple minutes. But if you could just bear with us just for a second. Okay, yeah. She'll message on the chat what she wants to say. I'll just start now, just so we save on time. So yeah, my name is Mohammed. I'm a fourth year medical student at the University of Leicester. I'm going to be giving a lecture on lower limb anatomy and a couple of clinical topics we can cover if we have time. So these are our partners for today, and I think we should be good to go. So I'm going to be covering a lot in this lecture. Here are those sort of learning objectives. So basically, this is going to be like a whistle-stop tour through, the entire lower limb anatomy from the hip all the way down to the foot. I've tried to make it as concise as I can, as relevant as I can, but obviously I won't be able to cover everything. And there are some clinical sort of topics I would like to cover as well, and maybe go into a bit of the surgical side of things if we have time. So to start off with, we're going to sort of talk about the hip bone. So you guys should already know what makes up the hip bone. You've got the ilium, ischium, and pubis, right? So the ilium is basically the largest part of the pelvic girdle. It's wing-shaped, and it has two surfaces. You can call it the external or gluteal surface, and then you've got the internal surface or the iliacal surface. And essentially, this bone has important landmarks for muscles. You should probably already know these. And we will sort of cover the landmarks first, and then we'll go into muscles and the other structures as well surrounding it. So, like I said, it's the largest bone. It's located more superiorly to the rest of the bones. So you should probably just remember that it's the largest bone. It's located superiorly, and you've got the wing of the ilium, which, if you can see my mouse, I'm sort of hovering around the main portion of it, and then the lower portion of it, which is what connects with the hip joint socket, is the body of the ilium, and it obviously also makes part of the acetabulum. We'll get into what the acetabulum is. It's basically a cup-like socket. Obviously, you've got the external surface and the internal surface, which we'll cover shortly with the muscles. So I wanted to sort of make this a bit more interactive as much as I can. We'll have some poll questions as well. But I want you to sort of take a moment to sort of guess or tell me, what each arrow's point was, just in your head. Just sort of say what you think each one is. We'll go through it one by one. So to start off with, you have the iliac crest. So the iliac crest sort of is at the apex of the ilium. It's a sort of roundish superior border, and at the very ends of this crest, you've got the next important landmarks. But before that, here you've got the sacroiliac joint. If you're sort of able to tell, this is the sacrum, it's the ilium. In between is the sacroiliac joints. Something that not many sort of people bother to remember, but it's obviously there. And you've got the anterior superior iliac spine. So at the very end of the iliac crest, if you're looking at this from the anterior view, you can see the anterior superior iliac spine. And if there's an anterior portion, there's obviously an posterior portion. If there's a superior portion, there's obviously an inferior portion. So it's sort of in the name. This is the iliac fossa, so the internal surface that we mentioned earlier. And by internal, we mean sort of not facing the buttocks. It's more internal in that it's facing the internal organs. So you can remember it like that. And it's a fossa because it's concave in its shape, and you can sort of see it in this drawing. The other side, the external surface, is convex in its shape. So you can then sort of appreciate what a 3D image of the hip bone kind of looks like. So you've got the gluteal surface as well that we already mentioned. So that's the origin for all of the gluteal muscles, which we'll cover shortly. The acetabulum, which we've already mentioned, we'll go into a bit more detail in a bit. The acetabular labrum, which makes up part of the socket in that it deepens it, and we'll also talk a bit about that, but essentially it's just the fibrocartilage that you get within that hip joint, that cup socket. And you can sort of see it there. It's like an incomplete C. So that's the labrum, and this entire thing is obviously the acetabulum, or the socket. You've got the acis, which is again, another view of the anterior superior iliac spine. So I think it's important when you're looking at the hip bone that you sort of see both anterior, lateral, and even posterior, because when you sort of try to picture it in your brain, or even just in front of you, usually you won't be able to, because you either haven't seen it before in person, or you just can't because of how irregular it looks. But once you see the different views, you can piece together what goes where. So just think of the names as well. They help you a lot. So crest, ilium, sort of somewhere along the superior. And then you've got the sacroiliac, so sacrum and ilium, so things like that. And obviously the anterior inferior iliac spine, which is sort of in relation to the superior in that it's just right below it. And these sort of have importance in terms of these notches here, in that this is obviously the greater sciatic notch. You also have a lesser sciatic notch. We'll sort of look into what that sort of means and what the relevance is in a moment. So before we do that, the ischium is the posterior inferior portion of the pelvic girdle. So that means it's sitting closer to the buttocks, below all the other bones here. So it's the lowest portion. It's also the furthest back. And essentially, the main portion you should know is the ischial body, the ischial tuberosity, and ischial spine, which we'll talk about in a moment. The iliac spine, which you can't really see at the moment, but that sits posteromedially to this body, sorry. So what that means is it sort of sits behind and more medially to the rest of the ischium. And then the ischial tuberosity is more posterior inferior to the body itself. So that means more lower down. So we'll sort of see that in a moment. So here, like I was sort of alluding to, it's postero and medial because it's pointing away, since this is the lateral view, to the ischial body, which is this portion right here. And then the obturator foramen, basically the importance of the obturator foramen in that it has, in real life, a membrane covering it, and then it has the obturator internus and externus muscles, which originate from this the membrane or the foramen itself. And we'll see that later on. The ischial tuberosity, like I mentioned, it's more inferior compared to the ischial spine, which is more sort of posterior-medial. And it's also posterior to the rest of the body, the ischial body. So try to visualize that in your head. Always try to remember the position that it's in relative to a certain landmark. So in this case, the ischial body. Then you sort of understand what the shape is. If you understand the shape, the 3D shape, you can sort of pick out what it is on a prosection or on a cadaver more easily. So we looked at the greater sciatic notch. We've got the lesser sciatic notch, which is part of the ischium in this case. And then you have the ischial body, and then you have the ischial ramus. So a ramus is sort of like a branch or a division. That's what it sort of literally means. So ischial branch, you can sort of see it sort of branching from the body, and it connects with the pubis. So if there's an ischial ramus, that means there's got to be a pubic ramus, right? So we're about to sort of see that. Now, the pubis is the most medial. It's the most anterior portion of the pelvic girdle, right? So because it's the most medial, that means it's got to connect with the other hip bone, because obviously you have two hip bones, right? So you've got the pubic body, similar to the ischial body, which is located medially, forms part of the acetabulum, which you can sort of see there. So I've highlighted what each portion is, just so you can better understand what goes where. And then, and then that obviously articulates at the very end here with the opposite pubic body, like I mentioned, at the pubic symphysis, which we'll see in a moment. So the superior and inferior pubic rami here will form part of this foramen, the obturator foramen. And then sort of relevant to the anatomy of the blood vessels, you've got the mid-inguinal point. And everyone usually just sort of mixes this up because there's two different points that you need to know. But the mid-inguinal point, so midway between the inguinal ligament, is between the acis and the pubic symphysis. And we'll sort of see that when we look at the inguinal canal as well. So the pubic tubercle is just a sort of prominence. So tubercle usually means a bony prominence. You can sort of see it there. And the relevance is that it will attach to a muscle, which we'll see in a moment. And then you've got the pubic symphysis, which is the joining. And again, similar to the sacroiliac, there's another joint. And it's obviously relevant when you talk about the mid-inguinal point. The obturator foramen, the superior pubic ramus, inferior pubic, the ischiopubic ramus. So sometimes they like to call this bone or this portion of the bone just one ischiopubic, but technically there's two bones here. And the reason why you sort of don't see that, it looks like it's just one complete bone, is because in your childhood, in early development, you have what we call a triradiate cartilage. So this fuses at around age 15 to form a complete bone in adulthood. But that's why we essentially divide it, because these are technically three separate bones. And then obviously the pubic body. So I've got sort of an image of the ligaments that you need to know, and they make up the greater and lesser sciatic foramen. So multiple ligaments here are known as sacroiliac ligaments, and it's in the name when it comes to origin and insertion, so you know that it originates from the sacrum. It inserts onto the ischial tuberosity. Sorry, I'm pointing to the wrong thing. Sorry. The sacroiliac ligaments should be right here. So the sacrum and then the ischial tuberosity. So these arrows should be there. That's my apologies. And then the sacrospinous is obviously this one, from the sacrum to the ischial spine. And then you've got the greater sciatic foramen, you've got the lesser sciatic foramen. So in the greater sciatic foramen, the borders are the laterally the ilium, medially the sacrotuberous, and then inferiorly the inguinal, the ischial spine and the sacrospinous ligament. So that forms the greater sciatic foramen, and then this is the lesser sciatic foramen, which is formed by both of these ligaments. Sorry, no. Yeah. This is the sacrotuberous, this is the sacroiliac, and then this is the sacrospinous. It's very sort of simple to understand what these are because they're in the name. And you can sort of piece together what the origin and insertion are. So the capsular ligaments, you've got 3 of them. You have anteriorly the iliofemoral ligament. You've got the ischiofemoral ligament, and you've got the pubofemoral. So again, think about the names of these ligaments, what the view is, so where they are going to be seen, which is that anterior, posterior, anterior, inferior. And then you've got what action they resist, what they essentially do. So iliofemoral ligament can be seen anteriorly, right? Originates from the anterior inferior iliac spine, inserts onto, with 2 separate ligaments, onto the intertrochanteric line of the femur, which is basically a imaginary line between the greater trochanter and the lesser trochanter. So if you think of like an imaginary line right there, you can see that this inverted Y shape, which is what this ligament is, the base of which originating from the anterior inferior iliac spine, and then inserting onto the intertrochanteric line of the femur. Now, the ischiofemoral, and also if you sort of think about it, if it's more anterior and if it comes from the ilium and the femur, you're going to think logically it's going to resist extension, because as you sort of extend so if this is your hip, right, and it's sort of extending this way, if you can see that, the anterior, because the ligament is anterior, it will sort of stretch and then resist that extension. So that's what it normally does. Now, the ischiofemoral is posterior, so it's the opposite, but its main function is to resist internal rotation of the hip. So it originates from the ischial body, and then it sort of spirals and inserts onto the anteromedial, so anteriorly. So it basically goes back to the anterior view and inserts onto the greater trochanter, which means that because of the direction of this ligament, it will resist internal rotation. So when you try to internally rotate, it will stretch and then it will sort of stop it to a point, the hip joint. Now, pubofemoral is anterior-inferior, resisting hip extension and abduction. So superior pubic ramus. So if we look at it right here, that's the pubic ramus, right? That we mentioned earlier. So the superior pubic ramus, and then inserting onto the same intertrochanteric line, but this time a bit more inferior. So just remember that the iliofemoral and pubofemoral share a common insertion, but all their origins are different. But you can sort of remember what they are based off of what the name of the ligament is. So ilio, origin, is the ilium. Ischial, body, the ligament's called ischiofemoral, and then pubo, superior pubic ramus. So that's how I remember them. And then the action sort of comes when you visualize these ligaments. So this is a summary of the entire bone. And you can see these are the muscle points where they originate from. You can see the wing of the ilium, or the external surface, marked by these gluteal muscles. And then you can see some of the obturator externus, you can see the adductor magnus. So some of these muscles, you can see them where they originate from. It helps you understand their origin point and also what they do. So the hip joint, like I mentioned, it's a ball and socket joint. It's a synovial joint, and essentially it's what controls the mobility of your lower limb. So because it obviously controls that, you have to imagine that the mobility, the range of motion has to be quite wide, right? And you can extend, you can flex, you can internally rotate, you can externally rotate, you can abduct, and you can adduct, right? So you need to sort of, when it comes to joints, you got to think about stability versus range of motion. So the more range of motion, the less stability. And then you can see where it articulates with the femur, so the head of the femur and the acetabulum form that hip joint. The acetabular labrum is fibrocartilage, and we'll sort of see fibrocartilage. It's in the knee joint as well. Deepens the socket, so it increases surface area, but also increases stability because it needs to make up for the fact that it's a ball and socket joint. So that's how you can sort of understand the hip joint. Now, muscle action, before we go on to muscles, I want to sort of go through these three principles that I learned in med school. So if you understand this, you understand, generally speaking, how muscles act. So principle one, the origin is the fixed point at the proximal end of the limb, while the insertion is the movable point at the distal end. So the origin being that fixed point. So think of like a wheelbarrow, and the fixed point being the wheel, and then you're sort of moving the wheelbarrow up and down. So that's the movable point, which is where your hands are really. That's the insertion. So usually the origin is the fixed point. It's usually at the proximal end of the limb, and then the insertion is sort of the movable point at the distal portion usually. But the origin, if you were to sort of fix the insertion, the origin then becomes mobile. So the roles sort of switch around. And then the orientation of the fibers, and this is why they sort of tell you what direction the muscle goes, because that's the direction of the fibers. If you understand the direction of the fibers, you can visualize it, you can then understand what the action is, right? Because muscles, they pull, they don't push, they only pull, but the length of the muscle is what changes, and that depends on the type of muscle, and it depends on the origin and insertion, right? So the direction as well determines that action. So that's going back to the basics. So we'll just go through the muscles now. We won't go into too much detail. This is more for like revision. I don't expect you to sort of come out of this knowing the origin, insertion, action, innovation. It would be great if you did, but these are sort of things that you need to look over again and again in order to understand. So really, it's sort of visualizing what these muscles are, what they do, where they are, right? So the gluteus maximus, the biggest muscle, right? You can see how big that is. Originates from that gluteal surface. So remember, we talked about the internal surface of the ilium and also the iliac crest, because you can sort of see it sort of originates close to that superior border of the ilium, and that's the crest. And then the sacrum. So the reason I've sort of bolded these two is because the gluteal surface and the sacrum make up the majority of this origin, and then the coccyx. So the insertion, and you can see what direction it goes. So if this is medial, this is lateral, and this is sort of going downwards because it's inserting onto that IT band. We'll talk about what the iliotibial tract is in a second. And then the gluteal tuberosity of the femur, which is around about here. So if you were to think about that, that's going infero-laterally, right? If it's going infero-laterally from the sacrum, from essentially the pelvis, and then it's inserting onto the femur diagonally and inferiorly, then a muscle that pulls means, if you can sort of visualize it now, it's externally rotating or lateral rotation, and it's extending the hip as well, right? To an extent, because you've got that infero-lateral direction. Then innervation, so this is where knowing your nerves, knowing the lumbosacral plexus comes into play. I will talk about it in the next couple of slides, but it's innervated by the inferior gluteal nerve, which is one of the sacral nerves. L5 to S2. Then gluteal medius and minimus, these are the ones that are relevant to Trendelenburg sign. So everyone should know what Trendelenburg sign is. The difference between the two muscles and the gluteus maximus is that one, they abduct, two, they internally rotate, they don't externally rotate. So think of the gluteus maximus as the odd one out in this case, in that it laterally rotates and it is responsible mainly for extension, right? The gluteus medius and minimus responsible for abduction, internal rotation. And they sit sort of right underneath the gluteus maximus. They've got the similar origins, so the gluteal surface, and then the ilium for the minimus, because the minimus then sits underneath the medius, and then inserting onto the greater trochanter. So the medius inserts onto the lateral aspect, the minimus inserts onto the anterior aspect of the greater trochanter. So the innervation, I always get these the wrong way around because I think superior means the bigger muscle, right? But just always know the superior gluteal nerve is related to the Trendelenburg sign, which is related to the gluteus medius and minimus. So that's how I can remember that. So we've got a poll question. And I'm going to start that poll. So I'll give you about 20 seconds, 30 seconds to just try to answer this, and then we'll go through it very briefly. I'll just read it out. So a 45-year-old male who recently underwent a right total hip replacement for a fractured neck of femur fracture has started to experience trouble with their gait. A Trendelenburg test is performed, which is positive for his right side. Please pick the correct set of answers. So Trendelenburg test is when you have someone stand up, and then you have them raise one leg in the air for about 30 seconds. So if you remember what that test is, then you can sort of answer this question. So that's, I'm not sure how I can sort of show answers, but the answer is C. So the superior gluteal nerve, and we already sort of hinted at that because superior gluteal nerve innervates the gluteus medius and minimus, and left-sided tilt downwards. So the Trendelenburg test, basically, so if you look back on the slides, I've sort of shown it here. You have someone raise their foot up. Normally, your muscles will contract, those gluteal muscles will contract and prevent both sides of the pelvis from sort of sagging or tilting up and down, right? But because you don't have that superior gluteal nerve innervation to the gluteus medius and minimus, they become paralyzed, right? So that means the safe side, and this is how I remember it, that a positive test is when the safe side sags, which means the affected side is the one that doesn't sag. So in this case, it's this side, right? So the right side. So that's how you can sort of understand what that test is. Now, the gluteal muscles, we've got them here. We're going to go over the deeper muscles now. So the deep region, starting off with the piriformis, you've got this muscle is basically triangular shaped. It's relevant because you can get what's known as piriformis syndrome. So I don't know if you've heard of that, but it's when the muscle becomes inflamed, particularly the tendon, and because of what structures go underneath and underneath it, can cause pain. And we'll see that in a moment. I want you to try and guess what nerve travels near this muscle that can cause that pain in the buttocks, and then think about why do you get that issue in the first place. I'll talk about that in a bit. So the origin, the anterior sacral wall, insertion, the superior aspect of the greater trochanter, so you can sort of see where it inserts right here, This is the greater trochanter, so it sort of inserts it above it, so superiorly. Then the action is to abduct and laterally rotate. So now you're taking what the gluteus maximus does, and then you're taking what the medius does. It abducts and it laterally rotates. And its innervation is just the nerve to the piriformis, which is very easy to remember. Now, the superior and inferior gemelli, the reason why I call them the thieves because they basically steal innervation from the muscles surrounding or near it, and they actually sort of squash this muscle here, the obturator internus. So that's how I remember it. The superior gemelli originates from the ischial spine. Can't really see the ischial spine right now, but if you were to remember from the sort of hip anatomy, it's basically where the ischial spine is, where it originates. And then the inferior gemelli, which is sort of lower down, originates from the ischial tuberosity. And it makes sense, right? Because the ischial spine is supposed to be more superior relative to the tuberosity, because we said the tuberosity was postero-inferior relative to that ischial body, right? So ischial spine superior, ischial tuberosity inferior, gemelli inserts onto the posterior aspect of the greater trochanter. So they share insertions to the greater trochanter, and then they obviously abduct, laterally rotate. Their innervation, I wouldn't say is it like something you should know for exams. It might come up, but if you remember that it's sort of these muscles steal from others, you can sort of then understand or remember which ones they steal it from, because the obturator internus and the quadratus femoris are quite close to these muscles. Obturator internus. So, like I mentioned, the obturator internus and the externus, they come off of the obturator membrane. The obturator membrane covers that obturator foramen. But in this case, the obturator internus originates from the medial surface, and then obviously the obturator externus on the lateral surface. So insertion, again, the greater trochanter. So you can sort of see the commonality, and that's how you can remember these muscles. Is if you just get a commonality between them. So think greater trochanter for insertion. Think, for the gemelli, think of the ischial bone, and you can then think of which one goes to where. That's how you can remember these muscles. And then its innervation is nerve to the obturator internus, which again also innervates the superior gemelli in this case. Whereas obviously the inferior gemelli, because it's closer to the quadratus femoris, is innervated by that. And then the quadratus femoris is more the odd one out in its action is sort of different to the others in that it only laterally rotates. It's got its own nerve supply, and it has its own tubercle, which it inserts onto. You don't really need to know this, but essentially it will insert onto the intertrochanteric crest or the quadrate tubercle. So it might be easier to remember quadrate tubercle if you're asked to sort of name that. And then obviously it originates from the ischial tuberosity. And it is sort of like a rectangle, which is why it's called the quadratus, so you can remember it that way. Now, I mentioned the IT band before, but there's a muscle that's relevant to the IT band, and it's called the tensor fasciae lata. So this muscle basically originates from the ASIS. It goes all the way down, and it inserts along the IT tract, the iliotibial tract, and I've sort of put a definition for what that tract is. It's just a thickening of the lateral aspect of the fascia lata. And its innervation is similar to the gluteus maximus, which is the superior gluteal nerve. So I understand I haven't gone through the nerves yet. I will in a second. But just remember that the tensor fasciae lata shares innervation with the gluteus maximus. Its action is to flex, abduct, and internally rotate. So you can understand how it can abduct by visualizing the direction visualizing the origin and insertion, and then thinking, okay, yeah, I can sort of tell that it goes this way, and it can also go sort of flex as well, and to an extent internally rotate, which is sort of why you've got to know exactly where a muscle is to be able to tell someone exactly what it does. Now, I was sort of told to sort of give some clinical relevance to these anatomical sites. So in the case of the hip bone, remember the ACIS, remember the greater trochanter, because when you're doing a ventrogluteal injection, which is usually done in adults and also children over the age of 7, this is an intramuscular injection. You would want to place your hand outstretched. You want to create a V shape to widen between the index and middle finger. And then you want to look for that ACIS. You can look for the greater trochanter as well. And on the lateral aspect of your hip, you can sort of try to feel it now. Try to get that feeling of the ACIS, which is sort of more anterior, and then the greater trochanter, which is more closer to your bottom, but on the lateral side. If you were to feel those two prominences, and then between the index and middle finger, you can then inject. And that's just something that you can remember. It might not be relevant to you if you're a second year, if you're a first year, but obviously it's good to know. But the dorsogluteal site, now they teach you this, but funny enough, you don't really do it in practice because it's risky. The reason why it's risky, and you can sort of read it there, is because when you take the glutes and then you create a quadrant, you're inserting onto the upper outer quadrant that you can sort of see there. Now, it doesn't look like it, but you do, like in this diagram, you can't really sort of appreciate it, but you can, if you do it wrong especially, you can hit these major nerves, sciatic nerve, you can hit blood vessels like the gluteal artery, which is why they don't really do this anymore. It's traditionally done. It was traditionally done, but from what I've read up and what I know, it's not really done anymore. Now, the lumbosacral plexus, basically, you can divide this plexus into the lumbar and the sacral. It's the same thing, really. Plexus means network. Lumbosacral is the combined network of these spinal nerves. Now, rami, I mentioned earlier, means branches. Ramus is a branch, rami branches. So the anterior division of those nerves, of the branches, is what forms this plexus. So the lumbar plexus is L1 to L4, sacral plexus L4 to S4. Now, L4 and L5 will sort of form the lumbosacral trunk. So that's basically where you get the combination of the two plexuses or plexi. Now, to start off with the lumbar plexus, so the way I remember this is always IGLOF, and you may have a similar mnemonic. I want to sort of help you visualize what these nerves are, because usually they'll just tell you that these are these nerves, these are the numbers, but you don't really know what those numbers mean. Well, you can sort of see relative to the spinal nerve or where it arises from the spine, you can see where it branches off and forms these specific nerves. So L1, ilioinguinal, there's a iliohypogastric, but that's not relevant in that it doesn't innervate the lower limbs, but they're both L1, right? And you can see that. That's L1. Genitofemoral, L1, L2, you can see how it branches and combines to form the genitofemoral. The lateral femoral cutaneous nerve, now, this is a purely cutaneous, meaning that it's only for sensory innervation. So it's not as relevant, but you should know it. L2, L3. So the way you can sort of remember this is if you think you're going from L1 at the very top and you're going all the way down to L4, And then as you go along, you pick up more nerves along the way. That's how you can remember L1, then L1, L2, then L2, L3, then L2, L3, L4, and that's the same for the obturator and the femoral. So it's easy to remember this. Igloff, you can use that to remember the names, but the names relate to sort of where they are, what they innervate. Obturator, because you can say it innervates the obturator muscles, and then femoral, because it will sort of innervate the muscles in the femoral compartment more anteriorly. And the last thing is that these divisions that we mentioned, you've got anterior and posterior divisions of these spinal nerves, and these are the spinal nerve roots. Most of these, except for the femorals, which I've sort of differentiated here, they arise from the anterior divisions of the spinal nerves, but the lateral femoral and the femoral nerve come from the posterior. But if you think about it, the lateral femoral cutaneous nerve and the femoral nerve, they innervate the anterior, so it can confuse you, but basically it's just the other way around, really. Like the divisions that make up these nerves, they're opposite to where they will end up in. So posteriorly, these femoral nerves will arise from the branches, but anteriorly, these other nerves will also arrive from the spinal nerve roots. So those are the nerves. I've got another poll. So I just realized that this question might not work because I don't know if you can see. So what I'll do is if you want to, I can just return that. Okay, so before I show the question, I'm going to show you this image. So basically what this question is it's asking you to identify two nerves on the dissection here. So imagine you're in the dissection lab, you see this, you see the cadaver, you're looking at the posterior aspects, you're looking in the gluteal region now. It's zoomed in so you can't really appreciate that, but I've sort of left some of these labels. So you've got the psoas muscle, you've got the quadratus lumborum. So this is looking through anteriorly. Because they've sort of resected and opened up the muscles. You can see these nerves here. Basically find the two nerves which match the femoral and obturator nerve, and then pick the right answer relative to what roots that these two nerves have. So I'm just going to resubmit the poll. So now that you've seen that, can you sort of tell me which nerve goes where and what the right roots are? So I'll sort of be a bit quick with this one. This is really, if you've been in a dissection lab and you've seen these nerves, that's how you're going to remember this. There's no other way really to understand what goes where. So the answer is A. So I sort of try to make it as hard as I could, just because once you sort of understand, you can sort of see the femoral nerve is quite a large nerve. You can attribute that to C, and then the obturator nerve is sort of close to the femoral nerve. It is E, but you're not going to get that on your first try, especially if you haven't seen a dissection yet. But here's the femoral nerve, here's the obturator nerve, and then surrounding that you can see the lateral femoral cutaneous nerve. You can see how thin it is. It's just for cutaneous distribution. You can see the quadratus lumborum, the iliohypogastric nerve that we talked about. So it sort of sits more above. It's not really relevant to the lower limbs, because the genitofemoral nerve here. All right, so the sacral plexus and I'm going to sort of speed things up a bit just because I'm wary of time, but a mnemonic to remember is CISP, like CISP. It's not really a word, but you can sort of keep that in your head and keep saying it over and over again. But the sacral nerves are harder to remember. The nerve roots are harder to remember, except for maybe the sciatic nerve. But it's sort of similar to the lumbar plexus in that you've got L4, L5, S1. Because if you remember, the lumbar sacral trunk connects the sacral to the lumbar sacral trunk connects the two plexuses. The L4, L5, S1 forms a superior gluteal nerve. The inferior gluteal nerve, L5, S1, S2. Sciatic nerve, L4 to S3. So that's the largest nerve. You can see how massive that nerve is because we know it divides up. It will innervate most of that lower leg and also the posterior compartment. So it has to be big and chunky. The posterior femoral is right there, S1, S2, S3. The pudendal nerve is not really relevant, so you can ignore it. But when you go into second year or third year, it will start to become more relevant. So S2, S3, S4, keep your shit off the floor. So if you just remember that, then you'll understand what that means later on when you cover it. So sciatic nerve root, I wanted to go through this because of how big the nerve is. The lumbosacral plexus, so the sciatic nerve initially comes horizontally from the lumbar vertebrae here, the posterior pelvic wall, right? Because this is posterior. And then it sort of goes or arises horizontally, but then it goes down vertically. So it's sort of like a water slide. That's how I remember it. Passes through the greater thoracic foramen. So if you remember the greater thoracic foramen, that was the sacrospinous ligament, right? And that creates that foramen for the sciatic nerve to pass through. And then you have the rest of this root. So through the greater sciatic foramen, underneath the piriformis, so inferior to the piriformis, is where the sciatic nerve goes through. Now, a lot of these vessels, a lot of these structures will pass underneath the piriformis. The superior gluteal nerve is an exception in that it goes above, but you should know that what goes under, what goes above, relative to what the name of the nerve is. So superior gluteal, that's superior, so above, and then you've got the sciatic nerve going through the sciatic foramen, going underneath that piriformis, and then it passes over these muscles. So the gluteus medius minimus goes over these muscles. Then, in order to enter that posterior compartment of the thigh, you've got this imaginary line between the greater trochanter and the ischial tuberosity. So remember those two prominences. Goes through into the posterior compartment, enters, goes over the adductor magnus. So again, you don't know that yet, what the muscle is, but it's essentially going through the posterior compartment, going above or sort of over that posterior surface of the magnus. Because remember, we're looking at this posteriorly, and then it goes underneath that biceps femoris. Remember, biceps femoris is way more superficial. It's the hamstring, one of the hamstrings. Goes underneath that, and then you can see here is the point, which is the popliteal fossa, so the back of your knee, dividing into the tibial and common perineal. Remember the common perineal nerve that wraps around that the head of the fibula, and then that tibial nerve goes down. We'll talk a bit about that later on. But yeah, so that's how you can remember the root. So try to think of a root in your head, visualize it. So these slides are meant to help you revise this, because you can just keep going through and tell yourself or question yourself, what goes first. So you've got the vertebra, then you've got the greater sciatic foramen, then you've got the piriformis, you've got the gluteal muscles, you've got that posterior compartment, so remember the border, and then you've got the adductor magnus, the biceps femoris, and then the popliteal fossa. So those things will help you understand what the sciatic nerve is. It'll help you sort of see that nerve in the section when you're sort of opening up that leg, so you can identify it on a pro section when it comes to exams. So cutaneous distribution, I'll just leave that there for your revision, but that's how you should remember the sensory distribution of these nerves. So the femur, and I'll go through this quickly because I know we're sort of short on time, but the femur basically has a lot of these landmarks for a lot of these muscles that you should know. If you're able to sort of, I've got a website, so I'm not going to go through all of this. Instead, I'm going to give you a website to use later on. It's a quiz. If you ever get stuck with, learning muscle anatomy, learning bony landmarks, look up purpose games, and then look up something specific like femur osteology, and then you can question. You can try to sort of try to speed up the time it takes for you to correctly guess what goes where, and that helps with memorization if that's your thing. So the head of the femur, self-explanatory. Greater trochanter, we've been sort of talking about this. The lesser trochanter is right there. So remember, this is the this is the medial aspect, this is the lateral aspect. This is the pectineal line, and then you can see the gluteal tuberosity right there combined. So the pectineal line and the gluteal tuberosity are basically lines that, or prominences that combine, sort of like a Y shape, and form that linea aspera. So the linea aspera is relevant to some of the muscles that we'll talk about that attach to this part of the femur. And this is essentially the anterior view. You've got the lateral medial supracondylar, so that means above the condyles. These are the continuation of the linea aspera. And again, you'll see why you need to know these with the muscle or insertions in a minute. And you've got the medial epicondyle and the lateral epicondyle. So epicondyle or epicondyle basically is something that sits above the condyles. The condyles are the prominences, or the usually round bony prominences that articulate with other bones to form a joint. The epicondyle doesn't, it sits above that, and you usually will get muscles that originate from there or even insert. So the adductor tubercle is relevant to the adductor magnus. And then you've got the other side, you can see the lesser trochanter, neck of the femur. So that's basically osteology. Now, here we've got the hamstrings, the posterior compartment. So you've got the biceps femoris long head, you've got the biceps femoris short head, which sits right underneath. The femoris is like a bicep, obviously in the name, like the biceps brachii, you've got the biceps femoris. And the origin is the ischiotuberosity. The insertion is the head of the fibula. And you can sort of see now, because it's originating from the hip, inserts onto the fibula, what it does, right? It doesn't necessarily, like, its function can be to extend the hip, but its main function, flexion of the knee, and obviously also laterally rotates because of that diagonal direction that it takes. It goes sort of more medially, then goes laterally, so that's inferolateral, which means it can then rotate the leg, or the thigh in this case. So extension of the hip, because it's in the posterior compartment, so remember posterior extension, anterior is more flexion, but it will flex the knee because of the knee joint, because it inserts onto the head of the fibula, which is part of the lower leg, right? So that means it will flex that knee, and it's innervated by the tibial part of the sciatic nerve, right? So the biceps femoris, short head, it sits a bit lower down, and it originates lower down from the linea aspera. So the linea aspera, we sort of saw that earlier. And inserts onto the head of the fibula. similar to the biceps femoris long head. And it obviously will flex and it will laterally rotate. It won't extend because remember, that muscle isn't originating from the hip, right? It's originating from the femur, the femoral shaft. So that means it's obviously not going to do that. So flexion of the knee, lateral rotation of the knee, and this time the common perineal part of that sciatic nerve. And then you've got the semitendinosus, which is the goose foot muscle because of where it inserts. So this term, pes anserinus, is basically just the medial aspect of the tibia. So whenever they try to tell you that, you sort of don't know what that means. It's just some random Greek or Latin term. It means goose foot, and it's basically three muscles. This is the first one, inserting over the medial aspect of that tibia below the knee joint. And then its action is to extend the hip, flexion of the knee, but medial rotation because it's on the medial side of the posterior compartment, right? And it's innervation by the tibial part of the sciatic nerve. So is the semimembranosus. So semitendinosus. So I sort of think of this as the longer muscle. It's more tendinous in that case, more sort of thinner. Semimembranosus is more, I think, more widespread, more fatter, or fatter. So originates also from the ischial tuberosity. So it's actually bigger than you think, but it inserts on the medial tibial condyle. So the pes anserinus is sort of specific to the semitendinosus, not the semimembranosus. It extends the hip, it flexes the knee, and it medially rotates because, again, it originates from a shared point, which is the ischial tuberosity. So do most of these muscles, with exceptions to the biceps femoris. Yeah. So I'm gonna skip this. I'll cover the adductor muscles. So you can sort of understand the obturator externus already, so the external surface of the obturator membrane. But the adductor brevis, adductor longus, and adductor magnus. So these adductor muscles will adduct, obviously, the thigh. These two have less of a role and are less important compared to the magnus, but they share the sort of similar origin or insertion and even origin. So origin being the pubis or the body of the pubis. In this case, the adductor brevis will originate from the inferior pubic ramus. The adductor longus is relevant to the femoral triangle that we'll talk about in a moment. So the femoral, if you remember the femoral triangle, so the adductor longus forms part of the femoral triangle. It originates from the pubic body. It inserts onto the linea aspera. So if you remember the linea aspera, that's posterior, by the way, inserting. And then adduction of the thigh, because it obviously, the way that it fans out, it's sort of like a fan, right? So I'll sort of show you what I mean by that. So I've highlighted what these muscles are. You can see it's like a fan, like one of those folding fans. Fans out, shares a similar origin, but it's not the same. Fans out infralaterally onto the linea aspera, because it shares that common insertion. But the adductor magnus has two components. It's got the adductor component, which means adduction, hamstring component, which means it's responsible for flexion, for extension of the thigh, right? It's a hamstring muscle, just extension of the thigh. And it adducts and it flexes. So basically it's 2 in 1. And if you remember, the hamstring actions is mostly to extend, right? Thigh. The adductors mostly is to adduct because it's an adductor magnus. It's part of the medial compartment, so that makes sense. And its innervation is the obturator nerve, as are the rest of these muscles. The superficial adductor originates from the inferior pubic ramus, the gracilis, and this is another one of those pes anserinus muscles. It's called the superficial adductor because it's most superficial. It's the most medial, I guess, and it sort of is like a strip of muscle. Goes from the pubic ramus and the pubic body all the way down, and then the pes anserinus, remember the medial aspect of the tibia below the knee joint. And it obviously adducts the thigh. It will flex the knee because it has that hamstring with the similar insertion to that semitendinosus. It will flex the knee similar to the hamstring muscles. It's got the same innervation. So I'll just go over these quickly. Rectus femoris. So you've got these muscles form the quadriceps femoris. The rectus femoris is one of the larger muscles. Its origin is from the anterior inferior iliac spine. So around about here, because that's the anterior superior. So the inferior is around about here. And the supraacetabular groove, which is just sort of right above the acetabulum, the rim of the acetabulum. And it has two tendons combining into one tendon, and all of these muscles, and you can see I sort of written it down, patella base via quadriceps tendon. So they combine to this single tendon called the quadriceps tendon, goes over the patella or inserts over and onto the patella base, which is sort of around about here. And also, so it inserts onto the patella base and the tibial tuberosity. It extends the knee. It will stabilize the patella because of its where it inserts. And in the case of the rectus femoris, it will instead extend the leg at the knee. It will flex the thigh at the hip because it originates from the hip. The vastus lateralis originates from the greater trochanter, so it won't do that. And the lateral lip of the linea aspera. So if you were to remember if you remembered from the osteology, you would know that the linea aspera has sort of a lateral medial lip. So originates from those two and inserts onto the patella base. The sartorius is a seatbelt because of the way it sort of goes diagonally, inferomedially, originates from the anterior superior iliac spine, goes all the way down, and it's the third and final muscle for the pes anserinus. So remember sartorius, semitendinosus, and gracilis. So it does a lot of things. That's how you remember it, like a yoga pose. If you remember that, you can sort of, and I've sort of drawn the direction of action there. So flexes, abducts, laterally rotates, flexes, and medially rotates the knee. So there's a bunch of stuff. And it makes sense because it goes all the way around. So we know it can affect the knee because it inserts onto the knee, but it flexes and medially rotates it. And then it laterally rotates the thigh because of the direction. Remember, inferior medial. And then abducts because it goes all the way from the asis, and when you pull the muscle, it will sort of bring it all the way outward. And innervation, femoral nerve. So remember the femoral nerve. Remember it supplies the anterior compartment of the muscles. Vastus medialis the vastus medialis obliquus is a portion of the vastus medialis. It's the oblique part. So the fibers, remember, they travel obliquely here, and it's important because we actually train this muscle to when you have patellar instability. You want to train this muscle to prevent a lateral displacement of the patella. Vastus medialis is obviously one of the muscles we talked about earlier, part of the medialis intermedialis and lateral vastus lateralis. So it's originating from the intertrochanteric line and the medial lip of the linea aspera. It inserts, similar to the others, the patella base, and it extends the knee, stabilizes the patella. So just remember that these muscles will stabilize the patella and they will affect the knee. So extend the knee, stabilize patella, with some exceptions being the rectus femoris and sartorius. And I've also listed the direction these muscle fibers travel, so you can understand the action. So the pectineus muscle, there's a pectineal line. Now, you don't really need to know that. You could just say the superior pubic ramus. It originates from the pubic ramus, inserts onto the pectineal line of the posterior femur that we talked about earlier, and it will adduct and flex the thigh at the hip. Makes sense, right? Because it goes more anteriorly, because the pubis is anteromedial, and then it inserts onto the femur posteriorly. So it will pull it and bring it up, and then adduct as well, because it's probably it shares, because people sort of debate whether it's the anterior or whether it's the medial compartment. It sort of is a bit of both, so that it adducts and also flexes. And it also has dual innervation, or sometimes can have dual innervation, because you have the femoral nerve, which mainly supplies it most of the time, but it can get supplied from the obturator nerve. And then the vastus intermedius, I don't think I mentioned that. Yeah, so we talked about the vastus lateralis, the vastus medialis. The vastus intermedius is between and underneath the rectus femoris. It has an origin on the femoral shaft, and then it inserts onto the patellar base. Again, it extends the knee stabilizes the patella. So I'll quickly go through this. So the arterial supply. So the femoral artery, and the most important part really is this part here, but we'll talk about the rest. So you've got the external iliac artery, and you've got the common femoral artery, and then you've got the common femoral artery, which divides into the deeper artery, which is the profunda femoris, and the superficial. So the deeper branch supplies that femoral shaft. So when you get femoral shaft fractures, you get a lot of blood loss, right? It's a life-threatening emergency. When you get a Knopf fracture, a neck of femur fracture, you affect the retinacular or the circumflex arteries, and the superficial femoral basically is a continuation of the femoral artery as it goes deeper down the thigh, going past the femoral triangle, going into the adductor canal, and we'll talk about the adductor canal as well. So the medial and lateral circumflex arteries are sort of circumflex, meaning they're like a ring, so it forms like a arterial ring. They're also known as the retinacular arteries. They wrap around that proximal femur. So not really around the neck, but when you do get these Knopf fractures, you can disrupt this blood supply, because remember, the head of the femur in early childhood, you get what's known as the artery to the head of the femur, or the ligamentum teres is what it is called in adulthood. That is a artery that closes off due to epiphyseal fusion, and you don't get that blood supply, so you're at risk of avascular necrosis in adulthood if this blood supply is disrupted. That's the clinical relevance. So I'm going to do a poll now. Here is the poll. So a 6-year-old woman fell from a flight of stairs and fractured her left hip, causing an intracapsular neck of femur fracture. So she fell down the stairs. She's an old lady, fractures her left hip. It fractures that neck of femur that we talked about. Which artery is most likely affected? And I kind of sort of told you which one. And what can happen to the head of the femur if the blood supply has been affected? So just so if you were paying attention, you would sort of be able to answer this question. It's very straightforward, which is why I'm just going to say it. It's B. So yeah, the medial circumflex artery. And remember, even though there's the medial and lateral, the medial circumflex artery is what's relevant and what is most likely to be disrupted in this case. And it can cause avascular necrosis. So avascular meaning a lack of blood supply causing necrosis of necrotic tissue, because that bone needs that blood supply. So you should remember that. Now, I'll go through this quickly. So the femoral nerve originates from that lumbar plexus in the abdomen. So remember L2, L3, L4, L2, L3, L4. So these branches coalesce in the abdomen, more like the posterior abdomen, passes through the psoas major, gives branches to two other muscles, which we haven't talked about, called the iliacus and the psoas major. As it travels through these muscles, meaning through the muscle fibers, passes underneath the inguinal ligament and enters that femoral triangle that we talked about at the mid-inguinal point, which is the relevance of that mid-inguinal point. So when we talk about mid-inguinal point, we're talking about the femoral nerve and where it passes through to enter the femoral triangle. The midpoint of the inguinal, and it's relevant because the midpoint of the inguinal ligament has its origins at the acis and the pubic symphysis. And we'll see that in a moment. It travels right underneath, sends its articular branches to supply that knee and hip joint. So the knee joint lower down, the hip joint above. And then as it passes through the triangle, it continues and it now becomes the terminal branch called the saphenous nerve. And it's a purely cutaneous nerve, meaning sensory. The saphenous nerve enters the adductor canal, which is right down here, and it supplies sensation to the medial side of the foot, of the leg, and the foot. So here's the femoral triangle. The easiest way to remember this is to think of the borders. So remember the adductor longus will form the medial border, the sartorius forms the lateral border, and the superior border is basically formed by the inguinal ligament. You don't really see it there, but that's the inguinal ligament. So remember the borders. Remember navel. So N stands for nerve, A stands for artery, V for vein, E for empty space, because there is supposed to be empty space, because the vein will, because of the blood supply, it's going to expand and shrink. So you need space for the blood blood vessels, and then the lymphatic system also travels down. So navel, remember E for empty space. The femoral ring, you can sort of see that there, containing the artery, vein, and lymphatic vessels. Passes all the way down. See the nerve goes all the way down, and it forms that becomes the terminal branch, the saphenous nerve, and then the artery. Remember the deep profundus, and then the superficial femoral artery, which becomes a continuation of the artery, goes all the way down into the adductor canal. So that's the femoral triangle. Now we're going to go over the knee, ankle, and foot, but it won't be in too much detail for the foot and the ankle. It'll be more focused on the knee. So here's the knee joint. It's a hinge type, meaning a hinge like a door. It's a synovial joint, and it enables mainly flexion and extension, but also some rotation as well. So this is a more stable joint compared to the hip, right? It's got a lot of ligaments. It's got a lot of ligaments externally and internally, or deeper. It has two articulations instead of one. So instead of that femur and acetabulum, you've got three bones and three or two areas. You've got the tibiofemoral groove and the patellofemoral groove, because remember, you have the patella bone. You don't see it, but you have the patella bone as well. So that forms that knee joint. And tibiofemoral is basically a groove that allows the tibia and femur to connect and articulate. Patellofemoral, again, for the patella and femoral femur. And then you've got the arterial supply, which is basically just the superficial femoral nerve that goes down to the adductor canal and becomes a popliteal artery. In reality, you have an anastomosis called the genicular anastomosis, which will vascularize that entire knee joint, which also means that the blood supply to the knee is quite strong. Now, here is the patellofemoral groove. So patellofemoral means femur, so this is the femur. This is the groove where the patella sits. you've got the condyles, which we talked about earlier, and in between you've got the intercondylar fossa or depression. You've got the epicondyles. Remember the epicondyles. And I sort of mentioned here, I've already mentioned this, but basically an epicondyle is a prominence above the condyle, and it's usually where the tendons of the muscles and ligaments attach to. So remember, condyle is for articulation, epicondyle is for origin insertion. Now, again, blood supply is quite vascular. You've got the genicular anastomosis, and you've got the popliteal artery. So yeah. Popliteus is basically the pop and lock muscle. I like to call it that because it's responsible for unlocking or unscrewing, I guess, the knee. Because when you sort of stand and you extend your knee fully as much as you can, it will lock it to keep stability, keep you standing, increase the stability as you stand. As it does that, it will immediately rotate the femur onto the tibia. So it's like a screw. So if you think of a screw, locks it in place, but the popliteus will undo that mechanism by laterally rotating the femur, unscrewing that knee. So because of that, you can call that the pop and lock muscle, but it's the popliteus, and it originates from the proximal posterior tibial shaft. So around about here, and then inserts onto the lateral femoral condyle. It originates from that proximal posterior tibial shaft, because obviously this is more medial. And then it inserts all the way on the lateral side, the femoral condyle, and also the meniscus. It's innervated by the tibial nerve. So patella is a pyramidal or a pyramidal type bone. There's a sesamoid bone actually, but it's sort of like a pyramid in a sense, or triangle. Main things to know about this is obviously it's got a base, it's got the apex or the tip. Relevance, the tendon of the quadriceps femoris, remember we talked about that, will insert onto the base, and the patellar ligament is also more on the apex. Anterior surface, posterior surface, you can see there's two facets here, the lateral facet and the medial facet. You can see the lateral facet is much larger than the medial. Its functions is to protect the knee, reduce friction, and basically, because of where it sits and how the tendon goes over it, it acts as a fulcrum because it inserts onto and goes over the patella, which increases the muscle's efficiency, really. So the menisci, which I mentioned earlier, similar to the acetabular labrum, they're fibrocartilaginous rings. They are C-shaped. They shock absorb and they increase surface area, so they're meant for stability and they meant to shock absorb. Think about it, if you're on your knee, if you're sort of standing all day, you're running around, I think about sports injuries. If you were to have someone kick you on the side of the knee, or if a ball hits you on the side of the knee, you'll want to be able to absorb that shock, or even just the fact that you are putting so much load, there's a lot of weight bearing onto those knees as you're standing. The rest of your body, the trunk especially, is transmitting a force downwards. So as you sort of jump up and down, for example, it can shock absorb that. So increases stability, deepens articulating surface, so it's similar to the acetabular labrum. It's got the medial and it's got a lateral meniscus, and it's crescent-shaped. You've got the anterior cruciate ligament, you've got the posterior cruciate ligament, and then you've got the intercondylar tubercles here, so bony prominence is right here. The relevance, so you can see where they sort of originate and insert. This is the intercondylar eminence, which is an area, or the intercondylar area between the intercondylar tubercles. You've got another ligament here called the transverse ligament of the knee. You've got another ligament called the posterior meniscofemoral because it sort of branches off from the lateral meniscus. And you've got the ACL and PCL. So the ACL, PCL, you would have heard that a lot. So it's something that you should already know the names of. But before that, I want to talk about these external ligaments. So these ligaments, basically, the patellar ligament, as we mentioned before, originates from the apex of the patella, and it inserts onto that tibial tuberosity. So the relevance of the tibial tuberosity is you can get what's known as Osgood-Schlatter's disease, which is repeated overuse, usually seen in children, quite active children, causes the bone to become larger than it normally would, and it can cause some infrapatellar pain. Essentially, patellar ligament is a continuation of that quadriceps femoris, so it combines with the quadriceps femoris and inserts over the tibial tuberosity. So the medial and collateral ligaments are important in that they resist that lateral and medial angulation that I was talking about. So the blows, so lateral and medial blows to the tibia and femur, these ligaments are meant to resist that angulation. So if you were to sort of test that and hold someone by their thigh and hold the base or the ankle, and you could move or rotate the ankle, angulate it laterally, medially, these ligaments activate and they will resist that angulation. And you would do that in a knee exam usually. They originate from the femoral epicondyles, the medial, collateral, medial femoral, lateral femoral, and they will insert onto the medial tibial condyle because it's on the medial side, that's where the tibia is, and because the fibula is on the left side, it will insert onto the head of the fibula. Just remember, the function is like the hardest part to remember here, but if you think about it, medial resists lateral, lateral resists medial. So the knee bursae, very briefly, synovial fluid creates these sort of pockets, which, or even bubbles, you could call them, but they're called bursae, and they reduce friction, mainly. They can become enlarged or inflamed, which is why you can hear things, which is why if you know like trochanteric bursitis, bursitis being inflammation. So these are the bursae. I'm not going to go into them in too much detail. You've got suprapatellar, you've got the prepatellar, the infrapatellar, the deep infrapatellar, the subsartorial, so remember the pes anserinus, that the proximal aspect of the tibia, and the medial aspect, and the semimembranosus because of where the semimembranosus muscle is. So the ACL and PCL are probably the hardest ones to remember when it comes to the origin insertion. Cruciate means cross, so think of your hands in your pockets, and then you can start to imagine what this looks like. ACL originates from that posteromedial aspect, so right here, posteromedial aspect of the lateral femoral condyle. The insertion goes all the way down to the tibia onto the anterior intercondylar area, which is around about here. Remember, anterior, posterior, this is more anterior. Intercondylar area, meaning between the condyles, the condyles. So think of a cross and think of where it travels towards, and then think of the function. So because it originates from the femur and it inserts diagonally and crosses over to insert onto the anterior aspect of the tibia, it will prevent anterior displacement of the tibia on the femur, and resist that lateral angulation of the tibia on the femur. So, which is why we do what's known as anterior drawer test or posterior drawer test, where sort of we grab the tibia, we sort of hold it in place, and we try to pull it towards us, and we feel for the laxity of the ligament. So, and ACL prevents anterior displacement of the tibia relative to the femur, and it resists lateral angulation of the tibia on the femur because it originates laterally on the femoral condyle, crosses, and then inserts of the anterior intercondylar area of the tibia. So it prevents the lateral angulation of the tibia. The posterior cruciate ligament is the opposite, so it originates from the anteromedial, so anteromedial of the medial femoral condyle, and it inserts onto the posterior intercondylar area. So the main bits to understand is the origin, which is the hardest bit to remember. But if you sort of visualize it, it becomes a bit easier. Prevents the opposite, so posterior displacement of the tibia, because it's posterior cruciate ligament, and medial angulation of the tibia on the femur. This is the popliteal fossa. So briefly, you've got the semimembranosus, you've got the biceps femoris, so forms the supero and the medial and lateral borders superiorly, and then the medial head of the gastrocnemius and the lateral head of the gastrocnemius. So the gastrocnemius muscles are these large posterior muscles in the lower leg, and they form the inferior borders, and it creates a diamond shape here, and that's the popliteal fossa. Contents are very self-explanatory: popliteal artery, vein, tibial and common perineal nerve because of the sciatic nerve. Remember, we talked about that. Popliteal lymph nodes and the short saphenous vein. So here's the tibia and fibula. I won't go into too much detail. Just know that you can look up on Purpose Games, you can look up any sort of osteology quiz, try to test yourself, because that's the only way you're really going to remember all of this. You need to visualize it. So try to label a image yourself and see how much you can get right. So a plateau, the medial tibial plateau sort of sits at the very superior aspect of the tibia, and you've got the lateral tibial plateau. You've got the Gerdy's tubercle here, which is just a bony prominence on the tibia, on the lateral aspect of the tibia. You've got the fibula head. You've got the tibial tuberosity, which is, remember, the relevance to the patellar tendon. You've got the interosseous membrane between the fibula and tibia. There's a gap in this membrane. It's sort of like a mesh, but it's just a membrane that is between these. And there's usually a gap around about here for the anterior tibial vessels to pass through. And then you've got obviously the medial lateral condyles, and then the lateral malleolus, the medial malleolus. So these malleolus bones are relevant to the ankle, and also to ankle fractures as well. Essentially, the main thing to take from this is to practice naming landmarks to remember them for your exams. Here's the bones of the foot. So forefoot, midfoot, hindfoot. Forefoot is the phalanges and the metatarsals. So you've got the distal and proximal phalanges. There's 5. You've got the metatarsals from 1 to 5. So 1 being all the way here, 5 being here. You've got the midfoot, which is the talar bones, cuboid, third cuneiform, second cuneiform, and first cuneiform. So there's 3 cuneiform bones. There's a navicular bone. There's a cuboid, and it does, and that sort of mainly forms that midfoot. And then the hindfoot is the talus and the calcaneus. So these are tarsal bones. This is the talus bone, and this is the calcaneus. The Achilles tendon will insert onto the calcaneus. The talus will form a mortise type joint, or it will basically form the ankle joint superiorly here. Inferiorly, you've got the subtalar because it's below the talus, and then the talo-navicular because it articulates with the navicular bone. The calcaneus because the calcaneus will articulate with the talus, with the subtalus, and then the calcaneo-cuboid joint anteriorly. Then you've got the calcaneal tuberosity for the Achilles tendon. The Achilles tendon is basically just a combined tendon from the posterior compartment muscles of the lower leg, which we'll look into. The cuneiforms, we've got the medial, intermediate, and lateral. These are wedge-shaped, and they articulate with the metatarsals and the navicular bone, and you can see where they are relative to each other. They're more medial compared to the cuboid. So the cuboid is most lateral. Cuboid is articulating here with the fourth and fifth metatarsal and also the calcaneus. You've got the navicular bone, which will articulate with the cuboid and the cuneiforms and the talus. So those are the bones. Try to remember the names. Try to remember the joints. The main joint is the ankle joint that you should know, and understand the actions of dorsiflexion, plantarflexion, inversion, eversion. That's the main function of the ankle joint. So the architecture of the foot. So you've got an imaginary line here called the transverse arch, which just joins the longitudinal arches. You've got the medial longitudinal arch formed by the multiple structures. So have a look at these structures. Try to remember a couple of these from each section. So because you have bones, you've got ligaments and muscles. So bones come easy because you can imagine what this line, where it travels. Calcaneus, talus, navicular, and the three cuneiforms. So, and the three metatarsals. And then the ligaments, the plantar ligaments. So the spring ligaments, also known as the calcaneo-navicular ligament. And then you've got the long and short plantar ligaments. And then the muscles, so the tibialis anterior and the fibularis longus. You're not going to remember this today. You're not going to remember this tomorrow. This is something that you've got to sort of sit down and read through and visualize. I've sort of created this arch here. If you were to sort of visualize this and then see what bones go where, and then the ligaments as well, then you can sort of understand what comprises each arch. The long plantar ligament is right here, and that's the spring ligament right there. So, and then the peroneus longus tendon right there. Now, the ankle joint is hinge typed. Again, it's a synovial joint. It's between the tibia, fibula, and talus. The tibia and fibula will join via these ligaments. So you can see the tibia, fibula, and then you've got the talus around here. So, like I mentioned earlier, there's a Maltese-shaped socket, or even joint, if you could call it that, that allows the talus to fit with the rest of the bones and form that ankle joint. Here are the ligaments, so anterior and posterior, inferior tibia fibula, because there's also a superior tibia fibula ligament. So you can sort of see calcaneus, talus, tibia fibula forms the ankle joint, and then you've got the anterior and posterior, inferior tibia fibula ligaments. And then here I've labeled the anterior talofibula because talus and the fibula join here, the talofibula ligament. You've got the posterior one obviously there, and then you've got the lateral calcaneofibular ligament. So main things really to get from this is these two ligaments here and the anterior and posterior talofibular ligament. That's all you should remember. That creates the ankle joint. that creates the lateral ligaments. So the anterior talofibular ligament, the posterior talofibular ligament, and the lateral calcaneofibular ligament form the lateral ligaments, and they stabilize the ankle joint. The medial ligaments are sort of triangle shaped, and they fan out, or they're known as the deltoid ligaments. Basically, the medial ligament prevents eversion, resists eversion, and then the lateral resists inversion. So we're going to do our fourth poll. So a 25-year-old male is admitted to the orthopedic ward for recovery after fracturing his fibula after falling from a playground swing in the middle of the night. So basically, he was found to have an abnormal gait, a foot drop. He sort of had absent dorsiflexion. But aside from that, I want you to try and think of another action that can be lost in this patient, one of the muscles that are involved, and the nerve that is affected. So think for a little bit, and we'll go over this one. So try to think, aside from dorsiflexion, and think about foot drop, what nerve is affected, what muscle is primarily affected, and the action that is lost. So the answer should be C. So eversion, fibularis brevis, and we'll understand a bit why, because I haven't explained yet, and obviously the common fibula because that's the nerve that supplies the muscle. So this will make sense when I talk about the actions of the ankle and the muscles associated, and also the nerves. So, but that's the answer. So, let me just get that out. So yeah, here are the actions: dorsiflexion and plantarflexion. I've split the muscles up based on their action instead. So this helps you understand what dorsiflexes, what plantarflexes. So dorsiflexion in green, the tibialis anterior, extensor digitorum longus, extensor hallucis longus. Green, innervated by the deep fibular nerve for the anterior compartment. Fibularis tertius is also part of the anterior compartment, but it will plantarflex instead of dorsiflex. So that's an odd one out there. The fibularis longus and brevis actually form a lateral compartment and innervated by the superficial fibular nerve. The tibial nerve, remember from the sciatic nerve, innervates the posterior compartment, and these are all the muscles you need to know. Gastrocnemius soleus, and then you've got the tibialis posterior, flexor digitorum longus, and then flexor hallucis longus. So right now you don't know what these muscles are, but I have a table that will sort of go through all that, which we'll cover in a moment. So tibialis anterior, remember tibial bone meaning, and anterior meaning anterior compartment over the tibia, and then tibialis posterior. So in terms of inversion and eversion, the tibialis anterior and posterior are responsible for inversion, and then the fibularis tertius, part of the anterior compartment, so with the tibialis anterior, and the fibularis longus and brevis, which are part of the lateral compartment, will evert. So it can be a bit confusing because they're different compartments, but they do different things. But this is sort of how you can visualize it and see what the compartment is, what nerve is innervated, what action it does. So now we know the muscle, its action, and its innervation. And you can get that just off of this one image for dorsiflexion and plantarflexion, and then for inversion and eversion. That's the cutaneous distribution. So that's just for you to see there. And it sort of corresponds to the common peroneal nerve, sort of wraps around the fibula. It will also supply that lateral aspect of the leg there. And then you've got the deep perineal. Remember, between the big toe is L4, L5, and the sural nerve S1, S2 on the lateral aspect of the foot. And then you've got that saphenous nerve as well. So you've got the anterior muscles, lateral muscles, and posterior. I don't have time to go through all of these, but this is mainly for your revision. And if you want to, you can sort of test yourself by covering different parts of this table. Just try to remember all of these. The best way really is to look at quizzes online to be able to identify the muscle first, and then think about origins and insertions. So tibialis anterior originates from the lateral surface of the tibia, and then it inserts onto the foot at the medial cuneiform and base of the metatarsal. So think about that. If it comes from the tibia and it wraps all the way around underneath and onto the base of the metatarsal, it's going to be responsible for dorsiflexion when it contracts, because it's on sort of the dorsum of the foot, and then it inverts the foot because of its position, because the tibia is more medial, so it will invert, and then if it's more lateral, it will evert. So tibialis anterior will invert, same with the tibialis posterior, and then extensor digitorums. So the digitorum and the hallucis are meant for the toes, mainly, or the phalanges. And you can sort of, I won't go into detail, but you can sort of pick apart what muscle goes where based off of the name, and remembering the insertion, and then going through the actions of each muscle. So briefly, the fibularis longus and brevis. The fibularis longus originates from the lateral surface of the fibula and the lateral tibial condyle. I'm just going to check the time just in case over time. Oh, okay. So innervated by the superficial fibular nerve, so L4 to S1, it's the lateral compartment, and main function is plantar flexion and eversion of the foot. Remember, going back to these actions, plantar flexion and eversion, which means plantar flexion and eversion of the foot. Lateral meaning fibula, so originates from the fibula, and then it inserts onto the medial cuneiform and base of the metatarsal, so kind of like the tibialis anterior, and then the fibularis brevis on the prominence of the base of metatarsal 1. If you go back to the osteology of the foot, right here, remember the numbers. So metatarsal 1, try to remember the numbers of the metatarsals, because sometimes you'll forget and you'll switch them around, and then you'll sort of get it wrong, even though you should know it. It's just a matter of remembering the numbering systems that they sort of have for these metatarsals, and it's the same with in your hands as well as the feet. You've got to remember those metatarsal 1 to 5, metacarpal 1 to 5. So that's something to keep in mind. And the main thing to get from this is these muscles, there's a lot to learn, and it's better to sort of divide it into tables and compartments and go through everything in terms of the action and the origin and insertion. And then you've got finally the posterior muscle compartment, so the gastrocnemius and cilius, more superficial. Remember the gastrocnemius relation to the popliteal fossa. It has two heads forming the inferior borders of the popliteal fossa. It's inserting onto the Achilles tendon similar to the cilius, onto the calcaneus, and its actions are to plantarflex. So all of these muscles plantarflex. And if you remember, the tibialis posterior alongside the tibialis anterior will invert the foot, The FDL or flexor digitorum longus is similar to the extensor digitorum longus in that it divides into 4 tendons and inserts onto the phalanges. So in this case, onto the lateral foredistal, same as the extensor digitorum longus, and then you've got the flexor hallucis, meaning big toe, so the base of the distal phalanx of the big toe. And that's all I'll cover for the muscles. For the tarsal tunnel, remember Tom, Dick, and Very Nervous Harry, because this enables you to sort of think medially to laterally, the tarsal tunnel and the vessels that go through that posterior ankle. And it's relevant because if you think about ankle fractures, think about what you have to do before. When you've got an open fracture, you need to reduce that fracture. You've got to stabilize and hold it. You may need to fixate that or fix that ankle in place, because remember, this tunnel contains important structures that, if disrupted, could mean you could lose that foot, right? Because you've got blood vessels, you've got sensation. You need to be wary of this, and anatomically, because then that translates to clinical practice. So Tom, Dick, and Very Nervous Harry stands for tibialis posterior. So from the medial, the most medial. Then you've got the flexor digitorum longus. So remember, that's the that's one of the compartments of the leg muscles. And you've got the posterior tibial artery. You've got the posterior tibial vein, and then you've got the nerve, and then you've got the flexor hallucis longus. Tom, Dick, and Very Nervous Harry. So that's something to keep in mind for exams. And then you've got, I want to cover sort of lower limb pathologies just to wrap it up. I know that it's covered in the next lecture, but this will be very brief. So this is going to be, I believe I have one more poll question. Let me just double check. No, it's in the slides. So a 6-year-old man fell from a 3-meter height where he landed on his left pelvis and presented with no pain, no deformity noted in other parts of his body. So here's an X-ray I took from Radiopedia, which shows the hip, and it's an anterior view, right? So this is a lateral view. Just take a minute to sort of think where that fracture is. You're probably not able to message, but just sort of think about where the fracture is and try to describe the fracture.
If anyone wants to put it in the chat, we can definitely read it out to you.
Oh yeah, if you're able to, I sort of showed it there, but you didn't see. If you can put it in the chat, what they think it is. I sort of briefly showed it. I thought, so I thought we were running out of time. If anyone wants to sort of be brave and answer where they think it is. I think you can do it in the Q&A, or if not, in the messages. Okay, so I'll just go through it. So basically, the way you describe this is obviously which side, first off, left. Remember, your left and right is inverted when you're talking about radiographs. Non-displaced, because you can see that the femur, even though it's more shortened, meaning it's higher up, hasn't. It's sort of partially displaced in this case, but it's really just hasn't moved from the proximal segment of the femur, of the head of the femur. So intracapsular, because it affects the neck. So a left non-displaced intracapsular neck or femur fracture. So it's not really relevant at the moment for like lower years, but basically when it comes to hip fractures, you've got intracapsular and you've got extracapsular. So in this case, this is an intracapsular. And you've got subtrochanteric and intertrochanteric for the extracapsular NOFs. Usually, we see NOFs in elderly. So think about why. So why do elderly people why are they more prone to um, to fracturing? Mainly falls, right? Elderly are more prone to falls because they are more frail, and because elderly are, especially females are more prone to brittle bones or in this case osteoporosis. Um, and then in younger adults, it takes but a bit more force. But in usually high energy trauma like car accidents, it's possible for a young adult to also sustain a NOF. Now, the management really depends on the type of the fracture, the person, the cause. What's best for the patient is always something you got to keep in mind. What a patient is going to be able to endure. So a 90-year-old lady, is she going to endure a hip replacement surgery, or is what type of hip replacement surgery would you do? And it depends on a lot of these factors. So clinically, you get severe pain and inability to weight bear. Like I mentioned, your leg shortens because of the fact that you've got your hamstring muscles, you've got your deep gluteal muscles as well. The gluteal muscles, they'll shorten that leg and also externally rotate. And then bedside, you want to do A2E. You want to order a hip series X-ray, which means AP lateral, and do some bloods as well. So you can think about what type of bloods you would do in this case. Initial management would obviously be analgesia, so what types. I guess, look up what you think, or try to look into what types of analgesia you could give. You want to treat any immediate life-threatening injuries. Definitively, it depends on the type of fracture. So intracapsular, you're thinking more total hip replacement, or hemi, meaning half arthroplasty, so replacement of the joint. And intertrochanteric, you would mainly do dynamic hip screws. So again, I won't go into detail what these are because you probably won't know it at this point. And this is mainly for anatomy, but that's just for your revision if you're sort of on placement, surgical placement. Complications, main thing, post-traumatic osteoarthritis, periprosthetic joint infections and fractures. Periprosthetic fractures and then prosthetic joint infections becoming, it's more of an issue when you are thinking of hip replacement, and then more longer-term complications. And obviously, physiotherapy, occupational therapy are one of the most important things or parts of a patient's journey as they sort of recover on the wards. PTOT, or physiotherapy, occupational therapy is something you'll hear a lot in your clinical years. So, yeah. So that's it from me. These are sort of the references. So I'm sorry if parts of that seemed rushed. It's a lot to cover. It's a lot for me to sort of go over. But yeah, should be it.
Amazing. Thank you, Mohammed. That was really, really good. And I'm sure that was really helpful for everyone's revision as well. If anyone has any questions, please feel free to put them in the chat too. In the meantime, I'm just going to go over a couple final bits for all of you. So the feedback form is now available in the chat. Don't forget to fill this out for you to receive your attendance certificates and discount codes to Teach Me Surgery and pass the MRCS. Also, be sure to complete the Google form that I have just put in the chat for a chance to win free access to the Kiki-Matic surgical flashcards and their OSCE stations. The link for this, again, is available in our chat. Our next session is going to cover clinical conditions of the lower limb, which is going to happen tomorrow at 6:30 p.m. So that's the 25th of February at 6:30. We'd love for all of you to join us again tomorrow. Make sure to follow us on our social media platforms, the links for which are available in our chat. Through these platforms, you will be able to receive updates on our upcoming sessions. We've also posted additional SPAs on our learning portal, so definitely check that out. Just as a reminder, membership for this learning portal is completely free, so definitely get one if you haven't already. And as a bonus, all of the SUPTA members are receiving 10% discount codes to Geeky Medic courses. We hope all of you found today's session helpful. Thank you once again for joining us today, and we look forward to seeing you all at a session tomorrow. Thank you, everyone.
Thank you, guys. Yeah, if anyone has any questions, I'm happy to answer them. I'll stay for a little bit, and if not, see you guys. And if you want to quickly sort of look at any of the other slides, like if you want to go over something real quick, just